Hello, everybody. Welcome to another episode of Doctors Go Live. So glad to be live. We're a bit late today because I was talking to myself earlier, but we didn't go live, but we are back live. So very happy to be here. I'm Nina Sharul Khan, your host for today's Doctors Go Live. And today we are talking about strategizing life expectancy of advanced cancer patients. Cannot speak properly as well. So anyway, this is a really important topic, and I would say it's even a heavy topic. So let us know who's tuning in right now. Where are you tuning in from? And what would you love to know or like to learn in today's episode, Strategizing Life Expectancy of Advanced Cancer Patients? Ask us. Let's use this platform to ask any questions you're worried about or concerned and really get you all the answers you really want to know. Yeah. So if you share this video out as well, you get to take part in our Doctors Go Live quiz happening right at the end. After the Q&A section, where you get to win today. It's an exclusive notebook and pen. Now, all this is happening right here on Doctors Go Live with me, Nina, and our special guest for today, Dr. Malwinder Singh Sandhu, Visiting Consultant Clinical Oncologist from Columbia Asia Hospital, Bukit Rimau. Now, cancer is known as an incurable disease, but today new progress in the diagnosis and treatment of cancer has played a significant role in extending the life expectancy of cancer patients, even if the disease is at an advanced stage. So what that means is that today, if you or your loved ones are diagnosed with cancer, there are new options and choices you can make to strategize life expectancy. What are these options? What are these choices? That's what we're going to cover in today's episode of Doctors Go Live. So if you know someone whom this info is going to be super useful, or if you think it's such an important topic and you want to share it out, and it's going to make a difference to somebody out there, please do share this video out on your social media, tag your friends, follow us on our social pages, because this episode is definitely going to make a difference. Hello, everybody. Welcome. So nice to see each and every one of you. Let's continue and have a look at this video today.
While we may never be able to cure cancer completely, there are a lot of new technological advancements which can help us to strategize the treatment options for you. I'm Dr. Malwinder Singh. I'm a consultant clinical oncologist in Columbia Asia Hospital, Bukit Rimau. Join me this 12th October at 3 p.m. for my talk, Strategizing the Best Treatment Option for You.
Hello. Welcome, everybody. We've got all the usual people that we meet: Soraya, Mary Hannah, Gwen, Q Shing, and Millie Chu. Welcome. Okay, so welcome back, ladies and gentlemen, to Doctors Go Live. And today we are talking about strategizing life expectancy of advanced cancer patients. And here to help shed some light on this very important topic, we've got you our expert for today, Visiting Consultant Clinical Oncologist from Columbia Asia, Bukit Rimau, Dr. Malwinder Singh Sandhu. Okay. Also, right at the end of the show, we have our Doctors Go Live quiz, where we've got some exclusive notebook and pen up for grabs. So you want to pay attention to our expert. Do we have him online? Okay. Oh, there you go. Dr. Malwinder, welcome.
Hi.
Thank you so much for joining us.
Thank you for calling me.
Okay, cool. So, ladies and gentlemen, if you have any questions, feel free to ask us in the chat, because right at the end of, Dr. Malwinder sharing, we're going to go into Q&A. So we're going to address those questions. Okay. So, Doc, first things first, Doc, can you share with us a little bit about yourself? How did you get started in oncology, and what is oncology for people who don't know, who are tuning in, they're brand new, they don't know what oncology means?
Okay, oncology basically means cancer. Cancer is divided into solid cancer and also blood cancer. So blood cancer is like leukemia and lymphoma, which is normally managed by a hematologist. Whereas solid tumors, solid cancers like breast cancer, lung cancer, colorectal cancer, that is being managed by an oncologist. Okay, it can be medical oncologist, radiation oncologist, or a clinical oncologist. So medical oncologists purely just do systemic therapy. Radiation oncologists purely do radiotherapy, whereas clinical oncologist is actually a person who subspecializes in both, where you do systemic therapy and also radiotherapy. So I'm a clinical oncologist. So I treat patients with systemic therapy from chemo, targeted immunotherapy, and also radiotherapy. Okay, how I actually got into oncology is actually by fluke. After I finished my housemanship, my boss told me, okay, we have a respiratory unit, need someone to take care for the cancer patients there. So I was thrown there. So I was
It happened. Okay, I think Doc is frozen, kind of thing. Is that right? Can you guys see Doc? Let me know, yeah? Okay, while we are checking, in the meantime, do you guys have any questions in today's episode? Let us know in the comment section so that we can answer it, okay? In the meantime, what are your experiences with cancer? Maybe some of you guys can share so that we can start talking about this. Because I feel that personally we don't talk enough about this, and we still think that it's the 10 years ago kind of treatment that's happening, and everybody is scared. It's the end of the world when somebody has cancer. So do share your experiences with it, and I think it's something that we need to talk about and we need to change, yeah, especially based on my little conversation with Doc. Okay, let me check where Doc is at the moment. Okay. And in the meantime, would love to hear from you guys. Are you guys okay? Suddenly so quiet in the chat. Okay, so there's a connection problem. Oh, there you go.
Yeah.
So
sorry.
That's okay. Okay, so
you heard my story?
We got to the part where, remind me where we got to the part, ladies and gentlemen. We got to the part where you were thrown into the respiratory unit. I hope I'm pronouncing it right. So what happened then?
Yeah, so when I was there, I got involved in seeing cancer patients from their diagnosis, treatment, and all. And then those days, there was not much choices. So I was there for quite some time. So I did see the development in oncology, and it sparked my interest to join oncology. So then subsequently, I applied for masters, and I went to University Malaya, and then I graduated and became an oncologist.
I see. So that's how you started. Okay, so it's definitely a passion thing. So you got to know all these cancer patients. Okay, fantastic. So going back to today's episode, why do you think it's important that we speak about strategizing life expectancy for advanced cancer patients? What is it that people need to know or don't know from your experience, Doc?
Okay, so when we are talking about cancer, right, there's a misconception which says cancer is a death sentence. Of course, if you are diagnosed early, that is very good, you're cured and all. But what about those unfortunate patients who are actually diagnosed in stage 4? So a lot of people think once when they're diagnosed in stage 4 cancer, be it any cancer like breast cancer or lung cancer, even colorectal cancer, is the end of their life. There's not much treatment available. Some might just don't bother to come to the hospital because it's already stage 4 and all. But I'm here today to explain that over the past 10 years, there's a lot of development in oncology in terms of systemic therapy, radiation therapy and all, where we can actually extend your life and try to make cancer as a chronic disease like diabetes and hypertension, where you can actually just live your life like a normal person and just carrying the cancer with just very minimal treatment, very less toxicity, and even some of those treatments don't even need chemotherapy nowadays.
Wow. So you're saying that even if it's the 4th stage, there is still option, and we can,
Yes, there's a lot of options. Never give up.
Okay. Never give up. Okay, awesome. Would you say that it's a lot to do with the mindset? Because most of the time people give up in their mind before even doing anything. Is that right, Doc?
I mean, mindset do play a small role. I mean, not a small, quite a big role also, because you need to be open for treatment options and all. Need to come to the hospital and all. You need some family support, emotional support and all. And then, of course, once when you have an open mind, you know what is going on with your body, you know what's going on with the latest evidences and all, then, of course, you might be more confident to undergo treatment.
Okay, got it. Definitely. So I love where this is going. So let's get straight into it then. What are we covering in today's episode, Doc? What will you be sharing with us?
So, As usual, a little bit about incidents, what's going on in Malaysia, and then what are the newer technologies which we have in cancer therapies. And then I'll be sharing one of my patients. And this is not just one of the best patient I have. This is one of the most common scenario which happen to most of my patients. So I'll be sharing the case and then we can learn together.
Wow, awesome case study. Love it, love it, love it. Okay, cool. So let's take a look at the first slide. First thing is statistics. Exactly how common is cancer, doc? It's become so common, right? Or
Yeah,
am I?
cancer is very, very common. So if you are looking in Malaysia, if you are looking generally in all the cancers, of course, breast, colorectal, and lung cancer is the most common. And when you're looking in females gender-wise, breast, of course, tops the most. And then second is colorectal, and third is cervix. So for females, breast cancer is definitely one of the commonest cancer to get. And even there is another misconception that breast cancer normally happens in females only. Males also do have breast tissue, so males also can have breast cancers.
Okay, got it. So it's become very common, right? And what about the number of cases is in our country? Is it an increasing trend or decreasing trend?
In reality, right, actually, cancer is definitely increasing every year. Okay, which
Okay.
we can actually see from our clinic census and all, and even if we talk to our colleagues and all also. Okay, but unfortunately, if I'm not mistaken, all this cancer registry and all, right, those proper evidence was not made mandatory until recently. So how we get all this evidence is when patient comes to the cancer center, then the oncologist will actually register them with the National Cancer Registry. So those days it was not mandatory. I think probably just about 2-3 years ago it became mandatory. So even this evidence is actually very, very underreported. There's definitely much more patients because you can see from the number of patients in our clinic and all.
Mm-hmm. Okay,
So
got
if
it.
you're looking in terms of death, of course, cardiovascular is like a sudden death and is number one killer in among all our population. But cancer is the second most commonest. Okay,
Mm-hmm.
and even if you're looking at the estimated death of a female gender, okay, breast, as you can see from the pie chart on the right hand side, breast is quite a big proportion, and then next to it is actually lung cancer. Okay, so it is one of the very, very common cancer, and people normally can die out of it also if you don't get it treated.
Okay, got it. So these are the data, yeah, that
Mhm.
we have. Okay. Now, what about this one here, Doc? Malaysia, do
Okay,
we
so
actually lag behind? Yeah.
yeah, in if you're talking about all this technology and all this therapy which is available, right? Whatever therapy you can get in overseas countries, like even talk about our neighboring countries like Thailand, Singapore, even Indonesia and all, everything is actually available in Malaysia. And if you're looking like Australia, US, Japan, whatever drugs which is launched there probably just take a couple of months and then it normally reaches Malaysia. So I wouldn't say we are actually very far behind in terms of our treatment. Okay, but our numbers is actually very, very less compared to the developing countries and all. It's because one major thing what I realize, even if you look at our statistics, a lot of our patients are being diagnosed at a later stage. Whereas if you're looking at the top three countries above there, most of their patients are diagnosed in a very early stage. So
Mm,
when you get diagnosed later, of course, your survival tends to reduce compared to someone who's diagnosed in an earlier stage. So that's one of the reasons why Malaysia is actually very low down the list compared to the other countries, which is in the chart there, which is like Japan, USA, and Australia.
Okay, so that's why we lag behind. So this is the
Mhm.
data, is it, Doc? It's be
Yeah,
uh,
so as you can see, the blue one is actually from 2007 till 2011, and the red one is 2012 till 2016. So you can see stage one is reducing, stage two is reducing, whereas stage three and stage four is increasing. Okay, but like I said, this is actually probably the truth or probably not the truth also because we really don't know. The National Cancer Registry was not made mandatory until recently. The
okay.
next evidence will actually come out, supposed to come out in 2021. Normally they do it every 5 years. So the latest one, I'm sure, will show more changes. But you can see most of our patients, okay, quite a number of patients is still being diagnosed in stage three and stage four.
Okay. Why do you think they're being diagnosed at such a late stage? Because this is something that we can change, right?
That's the thing. I also always ask my patient, why you all come so late stage? Okay, because breast is actually a very superficial organ. Okay, any abnormalities in the breast, you can actually detect it very simple. Okay, but people just tend to neglect it. Okay, because another thing is any breast lump, not everything is actually cancer. Normally about 80% actually just normal breast lump, 20% will turn out to be cancer. So some patients will just keep it, wait for it to grow, monitor tunggu dulu, tengok apa nak buat. Then when you delay the checkup and all, the cancer will start spreading. Once when it's spread, then you're going to detect in a later stage. So I
Okay.
think it's our
So
own perception. We don't come early for checkup.
right. Okay. So I guess yearly checkups help.
Yes, you need to do yearly checkup. There's always screening
Okay.
programs for all cancers.
Okay, got it. So in this case, the late detections is it because there's no yearly checkup, or they just keep waiting and waiting and waiting?
Okay, this is from my own personal experience. Those patients which
Uh-huh.
I have who are diagnosed in stage 3 and stage 4, when I ask them about screening, right, they never go for screening. It's just when they have symptoms, then they come for their checkup. So if
Right.
someone
And
who
by
goes through screening, they detect very early normally.
okay, got it. So basically, it's because they don't go for screening and checks, right?
Yes.
Okay, got it. And they come a bit late, lah. Okay. So what
Yes.
about this one, Doc? What can you share with us about this?
So this is actually the survival of a breast cancer patient. So normally when cancer patient come to me, they'll say, "Doctor, berapa lama saya nak hidup? How long am I going to live?" Okay,
Uh-huh.
so I cannot be sure because I'm not God, but what I can say is just through statistics. So whenever
Uh-huh.
someone asks me about survival, I always say, okay, we take about 5 years survival. If say 100 patient right now being diagnosed similar stage as you, if you're diagnosed in stage 1, 87 people will survive. If you're in stage 2, 80% will survive. If you're stage 3, 59% will survive. And you're stage 4, only 23% will survive. Okay. Now, bearing in mind, this evidence is actually from 2011. But after
Okay.
that, 10 years down the line, there's a lot of new treatment advancement and all. So let's wait for the new evidence, which is supposed to be published this year or next year. Then we will see at least stage 4 should be increasing their survival.
What do you think it'll increase to? I don't know if you can come up with a number based
Uh,
on your.
Okay, if those days you're talking like this, right? Stage 1, 2, 3, 4. Okay, this is just like a arbitrary stage. Okay,
Mm.
nowadays, if you look into the technological advancement, right? Okay, someone who is in stage 1, okay, and if they have a poor biology, okay, their survival might be same as someone who is in stage 3 with a good biology.
Okay, Cho,
Okay, so
what
nowadays,
is biology so that
okay,
we're all on the same page? Yeah.
so when you do your operation, your biopsy tissue and all, right? Normally you'll send to the pathologist for checkup to see what cancer is it, what are the cell types, and then in that particular biopsy, you can test a whole load of things to see whether the biology is a good biology or a bad biology. So that actually determines your survival. Actually,
The
okay, if you're
biology
looking at
is the biology of the cancer cells or
cancer,
okay, got
no,
it.
the cancer cells.
Okay,
Purely
got
on the
it.
cancer cells. So someone with very good biology can live very long, but someone with very poor biology, their survival definitely is shorter. If you're talking about stage 4 cancer, your biology is very good, your hormonal status all is good, your 5 year survival can go up to 60%. Compared to someone
Wow.
who's actually having a very poor biology and you're diagnosed in stage 4, then probably you're going to be about 20-30%.
Okay, so it's the biology state as well.
Yes.
What determines the biology state? Just wondering.
Okay, so stage is actually depending on three things. One is your tumor size, how many lymph nodes is involved, and whether the cancer has spread to anywhere else. Okay, so
Mm.
those are actually stage. When we are talking about biology of the disease, we look at the hormonal status. So for the biopsy, they will check and see your estrogen status, your progesterone status, your HER2 status, and then there's a few things to see the grade of cancer, grade 1, 2, 3, your Chi-67. This is a little bit more technical stuff, which normally the surgeon and the oncologist will discuss with the patient. So there's a lot of things which you can actually look from the report. Although it's just a one piece of paper, but there's a lot of information in that piece of paper.
Okay, got it. So that's more detail. And what about this, Doc? What is this slide about?
So this is from our National Cancer Registry also. So if looking at our Malaysian population, if you're Chinese, you have higher incidence of having breast cancer, followed by the Indians and then followed by the Malays. So these are ethnicity predisposition.
It could be because they come early for for screening. Maybe they tend to.
Maybe,
Yeah.
true,
Right. Yeah. So we don't
possible.
know why, right? Okay.
Correct,
Got it.
correct.
Okay. So I guess the question is, Doc, is this, Malaysia lagging behind? Is it something that we can control and change for the better, or is it something that we're completely not in control? And what do we need to do? How can we improve this? What's your opinion on that?
Of course, we can actually control to bring our numbers much better. Okay, one thing is actually screening. October is a breast cancer month. Okay, and everywhere you go, any cancer center or any hospital you go, always breast cancer is detected the most among October, November. Because there's a lot of
Ah,
free screening being done, so patients will go for screening and then they'll detect a mass and they'll diagnose they have cancer. But all these
okay.
campaigns, normally the moment October ends, those campaigns will start dying down. Then throughout the year, you don't get a lot of campaigns, so people will just forget about screening. And then the following year, when October comes again, another spike of screening will happen, and you diagnose much more patients. So
Okay, got
the
it.
screening need to be consistent. Once you go for your cancer screening, then you can detect your cancer earlier, and you can bring your numbers better.
Okay, got it. So basically, it's about going for screening checks and stuff like that, yeah,
Correct.
and
Yes.
being in charge of your health, right? Everybody, that's what we need to do. Okay, Doc, let's talk about this one. What is BCC timeliness framework? What is it? How does it help?
So this is actually just they took a few centers, a few cancer centers, and they took the data from them. So don't worry about the technical part of it. Just look at the last line. Okay. So from the date a person is diagnosed, I mean not diagnosed, from the date a person is having a symptom, you feel a breast lump or a lump under your axilla or something you feel is wrong. Okay. Until the day you start your treatment, it's an average of 4.9 months. Okay, so
Okay.
that's the problem with our local Malaysian population. When you have symptoms, you wait, you see more, tengok dulu, tunggu dulu. It'll take roughly about 2-3 months, and then the moment you go and see a doctor, if you're blessed enough to come to a private center, of course this can be cut short a lot. Okay, because we have all the facilities. Government hospital do have all these facilities also, but unfortunately they have a lot of number of patients, so they have to wait for their waiting list. So the procedure from them is a little bit longer. You go and see the doctor in the KK, then they refer you to the surgeon. Surgeon get a date for mammogram, biopsy, and then do go for your operation. Then only you send to the oncologist, then you do your treatment. So there's always a gap there, which roughly takes about a month or so. Okay,
Mm-hmm.
so always the moment you have symptoms, straight away go to the hospital, get it checked, and if possible, go to a tertiary center. Okay, when you go to a primary center, of course, like I said, can be non-cancerous. Okay, but of course, if you suspect it's cancer, go to a tertiary center, get it checked faster because those centers have all the facilities available.
Okay, got it. So basically, the average data for Malaysians is 4.9 months before they get their first treatment. That's very long.
Yeah,
So if we can shorten it, that'll be faster. Yeah, kind
correct.
of thing. Okay,
Because
and
cancer don't wait for anyone.
um, what would be a nice number instead of 4.9? Because 4.9 is too long, isn't it? So
There's
1 month.
there's no magic number. It again depends on your biology. Okay, like for the case later I'll present. If you have a good biology, the tumor grows very slowly. But if you have an aggressive biology, the tumor grows very fast. Within 2 weeks, you can see a lot of changes also. So if
Mm.
anything, the moment you have symptoms, straight away go for a checkup.
Okay, got it. Because there's a certain type of cancer which grows really fast, right? I can't remember the name. Even
Yes.
I didn't. Yep. Okay. And what about this one? The American Cancer Society recommendations for early detection of breast cancer. Can you share with us what this is?
So this is the screening program. Even in Malaysia, we have our own screening program also. The moment you hit 40 years old, okay, this is for average general Malaysian population with no risk factor. I'll talk a little bit about risk factor later. Okay, if you
Hmm.
don't have any risk factor, you should start going for your annual mammogram. Okay,
Okay.
every year one time go and do your mammogram and you can see whether there's anything there. If the doctor detect there is some abnormality, then probably you need to do a little bit more frequent, probably 6 monthly. Okay, otherwise 1 year once is good enough. Okay,
Okay.
once
And
when you hit more than 55 years old, okay, more than 55 years old, if you're stable all this while, then you can just switch it to 2 yearly. Every 2 years just do a mammogram. Okay,
wow.
but if
Okay.
say like I said you see something suspicious, then probably the doctor will ask you to do yearly or every 6 months or so. Okay, but if you are actually a person who have high risk factors, okay, high risk factors is like you have a genetic disorder. Okay, nowadays it's so simple. Just do a blood test. You can know whether you have a genetic risk factor of having cancer or not. Okay, so like here you've heard about Angelina Jolie. She has the BRCA gene. The moment you have BRCA gene, you're high risk of having breast cancer and ovarian cancer. So she went and removed her breast and removed her ovaries and all. So for someone who have strong family history of cancers, okay, and especially if you went for a test and you found out that you have BRCA gene, you can start your screening as early as 20 years old.
Oh,
Okay.
okay.
Yeah. So, but when you do screening for an early age, we don't tend to send them for mammogram because the breast is denser. So then we send for ultrasound. So sometimes some investigation need to be done complementary. Some do it ultrasound plus mammogram. Some just do mammogram itself. This will depend on the individual report.
Okay, got it. So basically, if you're a healthy person, you start doing your checks at 40, right?
Yes, correct.
Okay. If you have no problem, I think the majority of us, oh, no problem, we don't do anything. We wait and wait and wait. I think that's what happens. All right. So let's have a look at this one. So what about this one, Doc? Screening uptake has increased. This is data from Malaysia, right?
Yeah, this is from Malaysia. This is actually from the Ministry of Women's. So if you're looking, the orange one is actually from 2006, whereas the blue one is 2014. Okay, it's a huge gap, about probably 8 years. So in 8 years, we can see that mammogram uptake has increased. Okay, those days, clinical breast examination, which means you check your breast yourself or you go to the doctor and check your breast, is a screening tool. But nowadays, breast examination is no more a screening tool. Okay, because breast examination is very, very subjective. If your finger is not sensitive enough, you might miss a tumor or a mass. Okay, so ultimately still a mammogram and ultrasound is the gold standard to go for your screening. And definitely uptake has increased, okay, but it has not increased up to a level where we can see more of stage 1, stage 2 yet. So we need to carry on your screening program throughout the year.
Okay, got it. Okay, so those are some of the things that can be done, right, to
Yes.
improve. What about this one, Doc? How do you decide what treatment to do for your cancer patients? Because there's a lot of options these days, right, Doc?
Yes. Okay. So nowadays, cancer treatment is not the same for everyone. So someone who's diagnosed of, for example, a stage 3 breast cancer, if you go to a oncology daycare, you have 5 patients sitting down there. 5 of them have breast cancer. 5 of them have stage 3 breast cancer. Not all of them will have the same treatment. Because nowadays we are advocating personalized treatment, individual treatment, because everybody is different. So for me, it depends on the patient what you want actually, whether you're comfortable taking oral treatment or IV treatment, depending on whether you're fit enough to go through a toxic treatment or you're very weak to go through some treatment, your age, whether you have diabetes, hypertension, okay, and then menopausal status. Of course, premenopausal cancers tends to be more aggressive than postmenopausal status. Okay, and then looking at your disease itself, what stage are you in, your biology, whether it's a good biology or bad biology, your hormonal status. So these are the few things which actually oncologists will look at before we decide what is the best treatment for you. And then always, whatever treatment we recommend is always a discussion between the patient and the doctor. See which one suits them the most.
Okay, because it sort of affects the lifestyle as well, right?
Yes,
You know,
correct.
it's mm,
True. Nowadays,
okay.
even most of my cancer patients, when they go through treatment, they can go to work because nowadays everyone needs to work. So of course, we need
Mm.
to find some treatment which don't affect your lifestyle a lot. You can carry on with your daily activities and have a good life.
So, Doc, maybe you can share like 10 years ago, what was it like for a cancer patient in terms of treatment and how is it different today so that everybody can have an idea? Because I
I'll
thought that
say,
if you do chemo, you have the, and you're throwing up the whole time. So could you
okay,
shed some light?
okay. So I'll talk in general. 10 years
Yeah.
ago, probably you have very few targeted therapies available. There's no immunotherapies 10 years ago. Okay, everyone basically is treated by stage. Okay, and treated with chemo. Okay, and even chemo nowadays, you have newer generations of chemo, which is less toxic. And nowadays, you have a lot of new anti-nausea medicine, anti-vomiting medicine. You have booster shot to boost your cell counts to reduce the risk of having infection and all. And then those days treatment, probably you need to be admitted. Nowadays treatment, you just do it daycare. Come morning, afternoon, you're back home already. Next day, you can go back to work and all. So there's a lot of new treatments available. Some are oral, some are IV. Okay, some are even just subcutaneous injection where you just poke in your stomach like an insulin injection. Whereas those days you don't have all those options.
Mm. So today the cancer patients, they can actually do chemo and go to work the next day.
Yeah,
Yeah, okay. And no throwing up, nothing. Okay, impressive. Okay, got it.
true.
So what about this one? In terms of development of breast cancer treatment, some historical landmarks, if you could share with us.
Okay, so traditionally, surgery was always the mainstay, even up to now. Okay, if you want your cancer to be cured and you're diagnosed at early stage, like stage 1, 2, and 3, of course, surgery is a must to do. You can't run away from surgery. But even surgery, there's a lot of new advances. Those days, we remove the whole breast. Okay, and then you remove all the lymph nodes in the axilla. So some people at the end, after probably a few years, you get all the swelling of the hands because your lymph nodes is not there anymore, and cosmetic wise your breast is not there anymore. Okay, whereas nowadays we can actually have a lot of prosthesis where you can actually just remove the whole breast and you can do an implant straight away. Okay, or even nowadays you can just go for a wide local excision, which means just remove the tumor and leave the normal breast tissue inside, and you can do some reconstruction, put some fat tissue there, take some muscle and put there to make sure that it looks like a normal breast. Okay, and even the lymph nodes also, those days we used to do x-ray clearance, we remove all the lymph nodes. Nowadays there's something called sentinel lymph node biopsy where we just remove certain number of lymph nodes only, so that you don't get the problem of having swollen arms later on in life. Okay, of course, with all this new technological advancement, you need to go to a center which actually have all these facilities. Okay, so that's about surgery. Radiation also has been there for very long. Okay, in terms of breast itself, radiation to the breast, nothing much. Probably very little changes. Okay, not much changes. Those days you used to treat three-dimension radiotherapy. Nowadays there's something called IMRT, intensity modulated radiotherapy. It's just a fancy name, but whatever it is, it reduces the toxicity to the normal tissue. Okay, and
Right.
your lungs, your heart, and all might be safe a little bit more compared to the olden days kind of radiotherapy. Okay,
Mm.
chemotherapy from those days it has been there, even now it's still there. Is sometimes if you are talking about early stage cancer like stage 2, stage 3, those patients who need to go through chemotherapy in terms for that for them to survive longer. Okay, so chemotherapy is still a must sometimes in stage 2 and stage 3. You can't run away from that. Okay, but hopefully with new advancement, I would see probably in the next 10 years or so, maybe we might be able to get away with chemotherapy for certain patients. Okay, because normally in all this cancer development, right, always they start for patients who are in stage 4 first, clinical trial. When there's a lot of success, then they bring forward to stage 3, stage 2, and then subsequently stage 1. So nowadays in stage 4, there's a lot of treatments available. So, and some of it has already moved to stage 3, like targeted therapy in stage 3. There are clinical trials right now to use targeted therapy after surgery so that you don't need to go through chemotherapy also. But those evidence is not yet matured yet. So we just have to wait for that. Okay,
Got it.
hormonal therapy, those days it has been there for very long, but until recently only we found out that actually hormonal therapy plays a big role. Probably in the last 15 years or so, we found out that you have estrogen receptor, progesterone receptor, like I mentioned before. But if you're sensitive, you just treat with hormonal therapy alone. You don't need chemotherapy because you won't respond to chemotherapy if you're strongly hormone sensitive. And
Mm.
precision therapy is something new. I'm sure some of you have heard about targeted therapy, immunotherapy, next generation sequencing. So these are all bombastic words where we normally take your tissue, your cancer cells, we send it to the lab to see what mutation you have, what DNA you have, and then we test and see which drug will work the best. And then once you know what mutation you have, you know what drug will work the best for you. So these are personalized treatment. It's very precise to your cancer cells itself. So these are all evidence which is evolving at this moment.
Wow. Okay. So it sounds like it's completely different. Yeah. 10 years ago and today. So
Yes,
that's
definitely.
why. So that means if you're stage 3 or stage 4, there's much higher chances of survival, right?
Yes. Now this cancer
Okay.
survival is being pushed longer.
Longer and longer. Yeah. Okay. And what about this
So,
one? Speaking about survival.
okay, so this one is actually a survival chart for someone, for example, someone who's diagnosed in stage 4, okay, stage 4 breast cancer. So I'm talking about the biology, your hormonal status, okay, your estrogen, progesterone, and all, okay. So you can see if you have a good biology, the red line above, your survival is very high. Okay, the red line above. But if your biology is not so good, like the brown line, the bottommost, the fourth one, your survival is very short. Okay, people tend to die faster compared to someone who has higher survival. So these are all the same patient who's diagnosed same stage 4. Okay, you have the same disease burden, cancer spread to everywhere, but the biology determines how long you will survive.
Okay, so
Okay,
that's how the
so
biology works.
majority of breast cancer in Malaysia and even overseas, majority are always luminal A. Okay, so they survive the best. Unfortunately,
I
if you have a very bad biology, the survival is definitely shorter.
Okay, got it. So it's good that a lot of people have luminal A,
Yes.
right? Does
Yes.
age play a role as well in
Okay.
life expectancy?
Uh, Age plays a role, not in terms of treatment though. Treatment normally we look at your performance status. You can be a 70 years old coming on a wheelchair, coming on a walking stick, or you can be a 70-year-old running a marathon. You can't treat based on age. So we look at your performance status. Okay, but if you're looking at menopausal status, okay, less than 50, more than 50, just a number. Some people might be menopausal later or earlier. Okay, premenopausal cancer tends to be a little bit more aggressive, and postmenopausal cancer tend to be a little bit less aggressive. Okay, that's the only thing which differs in breast cancer. So if you look the one on the right hand side, okay, the hormone positive and HER2 is actually one of the bad hormones. So if you're hormone positive, like I said, the luminal A is about 65 to 75% of population. Whereas the very bad biology, the triple negative, those are 10% of the population. So only 10% have very bad biology. 75% have very good biology actually. But unfortunately, these 75% don't come for treatment or they don't go for their screening to detect early.
Wow. Okay. So that makes it harder.
Yeah.
Okay, got it. But knowing this data is good. So we should come earlier, right?
Yes, you should always come early. The earlier you come for a checkup, the earlier stage you get detected, less
Mm.
treatment, you go through less treatment, and the cost is much lesser. Compared to someone who comes at a later stage, the treatment tends to be a little bit more extensive and also expensive.
Because there's more that you need to do, right? Yeah.
Yes,
Okay.
correct.
Well, meanwhile, if you have any questions, please let us know in the comment section because we're going to be answering them really, really soon. Yeah. Okay. And what is this NCCN guidelines? Yeah. How does it play a role in what we're talking
Okay,
about today?
so when an oncologist wants to treat the patients, it's not just like you shock sendiri treat the patient. You need to go through by guidelines, go through evidence-based medicine. So NCCN is one of those guidelines. There's other guidelines like ESMO, ESCO, and all. So this is just a chart which I actually wanted to show to our viewer today. These are for stage 4 patients, for those with good biology. Okay, if any one of you who are in medical term, you can actually just breeze through the names of drugs and all, right? There's not even a single chemotherapy listed there. Okay, and
Wow.
all these treatments, okay, majority 90% are all oral treatment. There are only about 10% which are actually injection either by intravenous or by subcutaneous tissue. So even if you have a good biology, you're diagnosed in stage 4, you don't need to go through chemo actually. You can just go through some hormonal therapy, some targeted therapy, or even immunotherapy.
Wow. That's like mind blowing to hear. Yeah. And what about this one? Is this the same guidelines?
Yeah, this is just the evolution of the guidelines. Okay, so we are talking about those good biology people. Okay, so it
Mhm.
started off in 1937 and now up to the latest one, 2022. These are all the different drugs. I'm sure some of you have heard about it. Some of your friends are taking it and all. Even though some drugs are old, like tamoxifen started in 1973, it still plays a big role in our cancer treatment up to today. So these are all newer generations of hormonal therapy like your fulvestrant, your CDK4, your PIK mutation and all. There's a lot of things coming up.
Okay, got it. I think that's really awesome to hear. And what about this one, Doc? The duration of disease control.
Okay. So tamoxifen started first, one of the very old drugs, and subsequently we have new drugs called aromatase inhibitor, then came fulvestrant, then came the targeted therapy and all. Don't worry about the names. Look at the numbers on the right hand side. So those days, people who are just on hormonal therapy, you're looking at about 6 months survival, and then once with newer generation now, you can extend up to 2 years. Okay, so this chart is actually for PFS. You can see PFS, progression-free survival. So in cancer, we look at two things. Two things what I always tell the patient. Number one, how long I can extend your life, okay, by doing any treatment. Second thing, how long I can control the cancer before the cancer starts activating again. Okay, so PFS is how long I can control the cancer before it start activating again, where then you need to change to subsequent treatment. Okay, stage 4, one thing you need to understand, mutation keeps on changing, so your treatment need to keep on changing also. There's no one treatment I give you and you're going to survive 10 years down the line with the same treatment. Okay,
I
so
see.
PFS is how long I can control your cancer. So if you're just taking tamoxifen those days, I can control probably 6 months for a stage 4. Whereas nowadays, if you take the CDK4/6, I can control your cancer for at least 2 years before it relapses back again. Then you change to subsequent treatment.
I see. So it's kind of like the COVID, how it gets new variant, and then you got to get a new.
Yes,
Uh,
correct.
yeah.
It's like COVID and HIV. The mutation keeps on changing.
Right. Okay. Great. Cool. It sounds good. Sounds like there's more hope. Right. Okay. And what about this hormonal strategy, newer combination?
Okay, so this is the same like before, but this is for overall survival. Remember
Oh,
the slide before is how long I can control your cancer. This one, how
mm,
long you can survive when you do these kinds of treatment. So tamoxifen, you're looking at roughly about 43 months. Well, CDK4/6, you can go up to 5 years, 63 months.
mm, mhm.
So there are a lot of new treatments coming up where we will extend your survival even longer.
Okay. Okay. Awesome. Okay. And next, if we look at global breast cancer trials in Malaysia,
Yeah.
it's been
So
going
with
up, right?
all correct, with all these newer treatments available and all happen through clinical trials. Okay, without clinical trials, we will never know that this drug works and all, whether this drug is good, that drug is bad, or so. So there is a lot of clinical trials being run in Malaysia. Because what happens is when you talk about a drug, right, majority is always run in a Caucasian population. So we have already established in our oncology fraternity that Caucasian DNA is definitely different than our Asian DNA. So certain drugs, when they want to bring from Caucasian to our Asian countries, there are certain countries with regulatory approval where you need to have an Asian population inside those trials. So then they need to do a clinical trial in the Asian population, which is good for us because we know that this drug works well in a Caucasian population. We know those toxicity, the side effects and all. So now they just want to get regulatory approval, they do the trials in Malaysia. Malaysia and any Asian countries. Okay, so one thing good about all these things is the drugs are actually free. Okay, so all this targeted therapy, all these bombastic drugs, which I told you before to extend your life, it doesn't come cheap. It's quite expensive actually. Okay,
Mhm.
so if you are blessed enough to actually enroll in a clinical trial is not for patients who are actually like, oh, I failed multiple lines, I got nothing else to do, then I enroll myself in clinical trial. There's actually a false perception. A lot of patients will say, oh, I'm a guinea pig, why you want to put me in clinical trial? There are a lot of different versions of clinical trial. We have phase 1, phase 2, phase 3, phase 4. Of course, phase 1, phase 2 is very early. Okay, very, very early. So some of the drugs might work, might not work. Toxicity is not well known. So Malaysia don't get involved in a lot of phase 1, phase 2. We get a lot involved in phase 3 clinical trials, where you already have the normal standard arm, the standard of care treatment, and then you're testing something else. So either way, wherever you go, you will get the standard of care treatment, and you will get additional treatment if you actually are suitable for it. Okay, so for any patients who are very actively trying to find clinical trials, there's always this website called Malaysian Oncological Society. You can actually go there. It's updated every 3 to 6 months for all the latest clinical trial, where you should go, which center is nearest to you, and all the phone numbers which is listed there. Also, you can contact them. So here in Colombia, Asia, Bukit Rimau, we are one of the clinical trial centers for some clinical trials also. So if you have like certain colleagues or whoever who are having cancer who wants to know about more clinical trial, you can always come and see us also. We can discuss with you further.
Awesome. So Bukit Rimau is the place to go because you have clinical trials there. Right.
Yeah.
Is it offered in a lot of hospitals in Malaysia or not so? Just wondering.
Those big cancer centers, they do have clinical trial because clinical trial requires a lot of manpower. A lot of
Mhm.
workforce is needed. So big centers, you do have clinical trials, whereas small centers, you might not have clinical trials.
But you guys, because you specialize in it, right? It's a special
Yeah,
oncology center. You guys look
correct.
into it. Okay, fantastic. Let's take a look at what it's like. We've got some photos. Can you share with us about this job?
Okay, so this is actually a patient which I wanted to share.
Mm.
Okay, so this patient is actually a 50 plus years old Malay female. Okay,
Mhm.
she's actually an army officer. So she came to me, I think in 2016. Okay, where she came because she was having a breast lump. Okay, so at that point we did a biopsy. So she was in a very good biology. So she had the estrogen, progesterone positive, HER2 negative, those which are very commonly occurring in patients. So at that point, being a Malaysian, being an Asian, of course, tunggu dulu lah. So she disappeared. Then she came back 1 year later. Okay, after 1 year, she came back because she was breathless. So the breast lump was just growing very slowly. Okay, because it's a good biology, it doesn't grow very rapid. Okay, but cancer doesn't stay quiet. Of course, it's going to grow every day. So then she came with shortness of breath. So we did an X-ray. So her X-ray shows that there's actually water in the lung. So you can see the right side, the lung, everything is black, but the left side, the lung actually, only the top part is black, the bottom part is all white out because that's all water in the lung. So that's why she was feeling breathless. Okay.
This
Okay.
was one
So
year after she was diagnosed
1 year
with
after.
cancer.
Yes,
Okay.
correct. 1 year
And then
after.
didn't do anything. Okay.
So no treatment for 1 year because good biology won't cause a lot of symptoms. Okay. Okay. Can I have the next slide?
Oh, right. Sorry. Very engrossed with your story, doc.
Okay. So this is the CT scan. Okay, you can see the breast on the right side and the left side. The right side is very small, but the left side is very big because it's a huge breast lump there. Okay, and the CT scan on the right side also, I'm sorry, I don't have a pointer, but what I wanted to show is actually there's a lot of lymph nodes in the axilla, which is under the armpit. So normally breast cancer likes to go to the lymph nodes and always is below the armpit and then it goes up to the neck. So when she came after 1 year, she had a huge breast lump, she had water in the lungs, and she also had a lot of lymph nodes in the axilla. Okay. Can I have the next slide? Okay, so at that point in time, okay, we started her on a treatment called CDK4/6. It's an oral treatment. Okay, so it's just hormonal treatment plus targeted therapy. So she took oral treatment called aromatase inhibitor every day, one tablet. And then after that, we add on targeted therapy, the CDK4/6, which is also oral treatment. So she had it for 2.5 years. Remember the first photo I showed you before? If you're on CDK4/6, I can control your cancer for about 2 years. So about
Yep.
2 years or so, she actually had the treatment and her water in the lung, everything cleared up. Okay. So in between that, we did a few scans down the line. Practically, you don't see anything in the scans. Okay, her huge breast tumor actually disappeared. Her lymph nodes also disappeared. Okay. Now, one thing I must stress to our audience today is when you do a scan, okay, and you see a tumor disappearing, okay, although it's good to see in the eye, those are all macroscopic tumor, okay, macro big, which eyes can see, okay, but the microscopic cells, those small cells, will definitely be there. It will never disappear. That's how the cancer always tend to grow later. So a lot of our population, the moment you do some treatment, you say, hey, I'm getting better already. Hey, I don't feel anything already. Scan show clear already. Why I want to spend some more money? Why I want to go through treatment? I want to stop treatment. So that's the misconception. Okay, she was one of those lucky one because CDK4/6, right? Those treatment can actually shrink the tumor very fast. And she was lucky enough that everything disappeared. Okay, so she was on the scan every 6 months, all cantik, no problem. After 2.5 years, she came and she had one small lung mass. Okay, the one on the left side, you can see one white color dot, whereas everything else looked black. So that is actually a new growth. It was not there in the previous scans and all. Okay, so the tumor controlled very well for 2.5 years, and then subsequently the tumor grew.
It
Okay.
mutated. Is that what
Yes,
happened?
probably mutated. Okay, and then after that it grew, and there's only one lesion in the whole CT scan. Okay. Okay. Next slide. Okay. So this one you see some color there. So this is how we get new technologies incorporated for us to have a better treatment for a patient. Okay. CT scan will show you black and white. Okay, whether it's normal or abnormal. PET scan will show you activity. If there's color, it means the cancer is active. If there's no color, the cancer is not active at the moment. Okay. PET scan also has its limitation. It cannot show microscopic disease. It will only show some like millimeters and above, maybe it will show. Those smaller, it might not show. So when we did the PET scan for her, we found that there's only one lesion which is the same as a CT scan, and there's only one uptake there. Okay, so which is a good news actually for her because even after 2 years, her tumor grew and only grew at that one particular location. So when there's only one particular location, there's a few options what you can do. You can either remove that by surgery, okay, or you can actually give radiotherapy. try to burn it off, or you can actually use cryotherapy. You can freeze it with ice, or you can burn it with RFA, also some radio frequency ablation. There's a lot of treatments available, but the patient didn't want anything invasive. She don't want to go through a lot of trauma. So radiotherapy is one of the options where you don't need to go through any surgery or any poking or anything. You just lie down, like radiation beam, X-ray beam will just be shooting in your lungs, and then the tumor will actually die off with it. Okay. Okay. Can you show
So
me
how
the
many
next slide?
radiotherapy did she do? Okay, we need
Okay.
our video.
There's a video. Yes.
Yes.
So this is actually when we do radiotherapy. I offered her radiotherapy because she doesn't want any surgery. Okay. So when we do radiotherapy, there's a process where we need to do called simulation. So simulation is where the patient comes to the hospital. We lie down, we scan you, we see where's your tumor, how's the tumor moving with your breathing and all. Because when we give radiotherapy, we want to be very precise. The radiation has to move with your tumor. We can't be shooting an area and suddenly your tumor moves when you breathe, and then we are shooting an empty place there. Okay, so this is a breathing scan. So we see the motion of the tumor, how the tumor moves, and then we plan our radiotherapy accordingly to that lesion there. Can you go to the next slide? Okay, so this is actually the radiotherapy which we did. Okay, when we talk about radiotherapy, I did say there's a lot of advancement and all. So you have 3 dimension, you have IMRT, you have something new called SBRT, stereotactic body radiotherapy. I'm sure a lot of people have heard about gamma knife to the brain, knifeless surgery to the brain. Yes, so those are all brain radiotherapy. Those same concept is used for below the brain. We call it stereotactic body radiotherapy. So we give a very high dose of radiation just to that tumor, and you can look at the dose distribution. Nothing is being splashed outside very far. It's just around that tumor only. And the blue one is the low dose, the red one is the high dose, and the white color one is the most highest dose in the center. So the
Right. So
patient
it's
just,
targeted.
yes, it's very targeted. So the patient just comes, lie down, and then we do the scan, position her, everything, and then we shoot the radiotherapy. The radiotherapy will just be probably about 5 to 7 minutes, and then after that, patient can go back home. So it's a daily procedure, and she just come for 5 times. She
Oh,
doesn't need to
5
do the
kali.
long.
Okay.
Kali saja. Don't need the long radiotherapy like 3 weeks, 6 weeks, and all, because it's high dose, precise to the location, less treatment time. Okay, so we gave her that, and then subsequently, I just continued on with the CDK4/6 because everywhere else was responding except that one stubborn lesion. So the mutation happened, which caused this lesion to grow. So I gave radiotherapy and I burned that lesion. Okay, okay. Subsequently, next slide. Yes. So this is what I wanted to show. If you look at 2 dimension, 3 dimension, IMRT and SBRT, your tumor size is the same, didn't change. Okay. But the blue color normal tissue, 2D, your radiation to the normal tissue is much higher. 3D radiation is much smaller. And if you're looking at IMRT, SBRT, your radiation to the normal tissue is very much smaller. So these are all radiotherapy advancement.
Right. So as we go along, basically modern radiotherapy reduces radiation to the normal
Normal
tissues.
tissue.
Yeah.
Yes.
Fantastic.
Right. Okay. Next slide. Okay,
So
so
this
1 year
is
later, these are the changes in the CT scan. Okay, first time when we did the CT scan, my radiologist actually reported that actually the tumor has grew. Okay, but actually no. When you do radiotherapy, okay, you're burning that area. When it's like a normal scar. When you have any scar, you fall down and all. Of course, the skin there will be hardened, right? It become hard. So same thing in your lungs. When I give radiotherapy, or even if you go for a lung surgery or anything, those area will heal by fibrosis. Fibrosis means hardening of your tissue. So those white patches there are all fibrosis only. These are all radiation side effects. Clinically, you don't feel anything because you look at your lung, it's actually very huge, and the fibrosis region is probably just about 3 centimeter, whereas you have a 20 centimeter lung to breathe with. So clinically, you don't feel anything. So we did a PET scan subsequently also to show that this one, there was no uptake. So no uptake means there was no active cancer there. It's just fibrosis only. Okay, and this fibrosis will carry on throughout your life. Okay, then that was 1 year after. Then subsequently another year after that, okay, when we did the scans, we found that she actually has tumor in the liver. Okay, something grew in the liver subsequently. Okay, because breast cancer like to go to your lung, bone, and your liver. Okay, so 1 year after that, which means she was on CDK4/6 for at least about 3 years. Okay, 2 years, then the thing grew, I radiate that, and then I continue another year, then the liver started growing. Okay, so when I did a PET scan shows color. Okay, color showed, okay, there's something in the liver. So then I discussed with her again, same option still available. Either you go for surgery, you freeze it with cryotherapy, or you burn it with RFA, or you go for stereotactic body radiotherapy. So she had very good experience with the first episode. So she decided, okay, I want to do SBRT again for the liver. Okay, okay, next slide.
I
Sorry,
need the
the
video.
video. Yeah. So lung, liver all move with your breathing. Okay, so definitely we need to do your breathing scan, see your liver movement and all, see how much liver is moving, where is the tumor, how is it moving. Then we aim the radiotherapy to that region. Okay. Okay, next slide. Okay, now when we do radiotherapy to the liver, it's a little bit more different than radiotherapy to the lung. Part of the liver SBRT, you need to do a more sophisticated CT scan called CT 4-phase. Okay, so when we did the CT 4-phase, we found that she actually had two other lesions. Okay, where PET scan didn't pick up. So this is what I mean by using more modalities to actually fine tune the best treatment for you. So you do a PET scan has certain limitation, MRI has certain limitation, CT scan has certain limitations. So sometimes you need to join a few scans to get the best treatment options for her. So when we did the scan for her, we found she had total of 3 lesions. So I radiated all 3 of those lesions. Okay, next scan. Next slide. Yes, so this is the other two which we found, which was not in the PET scan initially. Okay, next slide. Okay, so this is just a rough summary, okay, where she had all her treatment and all. Okay, after she had SBRT of liver, 1 year after that again, okay, probably about 13 months or so, her tumor actually grew again, where she had more liver lesion, more bones lesions and all. Okay, so that time she already had this targeted therapy called CDK4/6 for quite some time. So it's time to change some treatment already because I cannot give SBRT when there's a lot of lesions. Very small lesions, I can give SBRT. Many lesions, you need to change to a new treatment. So then came the next generation sequencing. Okay, where I biopsied her liver, the new lesion which is growing, and send it to the lab. So the lab will do all the DNA testing to see what mutation is positive, what mutation is negative, what drug will work best for her. So we found that she actually has this mutation called PIK3CA mutation. Okay, so when we know that mutation, then we know there is a newer drug which is called alpelisib, which we can actually use to target those mutations. So then I started her on that drug. So now that she's already on that drug, she's already surviving up to 19 months on that drug without any tumor recurrence at the moment. Okay, so from the time she was diagnosed until now, okay, she has survived for 6 years. She's diagnosed with stage 4. Initially, she came a lot of water in the lung, breast mass very big, axillary lymph nodes a lot. Just took oral hormonal treatment, oral CDK4/6, and this treatment practically has not much toxicities. The main toxicities is only to your blood count, so you need to come for a monthly blood checkup. Okay. Otherwise, probably just some skin itchiness here and there a little bit, but no nausea, no vomiting, hair don't drop. You can go back to work and all. And then the tumor grew in the lung where I gave radiotherapy, practically no toxicity also. Then liver, again, I gave radiotherapy, no toxicity also. Then tumor growth, I changed it to these new drugs. But of course, these new drugs has some toxicity. It can increase your blood sugar level, which she had those problems. So she's on anti-diabetic medication right now. And she's continuing with her treatment until now. She's surviving for 6 years and she carry on going to her work and all.
Okay, so this is
So
like no chemotherapy.
no chemotherapy.
Yeah, amazing. If you
So
guys
you
are
have a
tuning
lot
in,
of new technologies actually coming up. You can actually use a lot of systemic therapy, different kinds of radiotherapy, different kinds of scans to get the best results, NGS, a lot of things are coming up. And this is just the
okay,
tip of the iceberg. I think the
this
years
is
pass by, you will get much more.
yeah, and it's fourth stage, right? I would assume they're like on chemo. I mean, you naturally assume fourth stage confirmed chemo and like bleh, 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 for lack of an explanation. Okay, all right. So at the end of the day, doc, okay, in your experience, what are the most common mistakes that people make when it comes to cancer, in your opinion?
Okay, number one, always they come at a late stage. You don't go for your normal cancer screening. Okay, some people when they have any symptoms, they always try to think of something else, nothing related to cancer, so they just wait, delay their time and all. Okay, and then once they start any treatment, okay, finding the right treatment for a patient sometimes takes time. Okay, it's like a trial and error thing. Okay,
Mm.
so some patients get very bad toxicity, some patients don't get toxicity at all. So if you have any toxicity, always talk to your doctor. Of course, we want the best for the patient. If you have a lot of toxicities, we are not going to force you down the line to go through all those treatment. We can always fine tune, change a little bit and all. The moment some people have some toxicity, they start to run away. They don't want to do their treatment. Okay, so that's one problem which I face also. Okay, another problem on the other
All
end
your
is
patients
some
run
patients
from
who
you.
go through. Okay, so another patient who have treatment very well, tumor all disappeared, and then they say, okay, I want to stop treatment. So that's another spectrum of patients which really need to understand that these are all macroscopic disease which has gone, but microscopic is still there.
Right. Okay. That's why they say that, once you have it, it's going to be prepared for the long journey, right? It's going to be
Yes.
in there. And they can only call you cancer free if it's not there for 5 years. That's what they
Uh,
say. Is that true?
that's what people say, lah. People say.
Okay. All right. One last question. Do you have any tips or advice to people out there, whoever's tuning in, when it comes to strategizing life expectancy of cancer patients? What's your advice? What do you want people to take home at the end of the day? What can they do?
I always want them to actually come for early screening. Although I talk all these fancy things, you can survive very long and all with all this new treatment and all, right? But nothing beats being diagnosed early, and you don't need to go through all this treatment and spend a lot of money on it. Cancer screening is very important. Okay, early detection always saves lives. Always go for your screening, get detected early. If you're unfortunate, you're detected late stage, there's a lot of treatment options available. Just talk to your doctor. Your doctor will explain everything to you.
Okay, got it. We're Asians. We want things cheap and fast, so
Yeah.
come and get
Then
your
enter clinical trial.
yeah, and clinical trial. But we don't want to go to clinical trial. But then it's already, you know,
No,
bigger
no, you
things.
can go to clinical trial. You get good medicine there.
Okay, got it. Okay, so clinical trial and come to early. Yeah, I think a lot of people don't know about clinical trial. Okay, let's go into the Q&A. Let's start with Nor Ida. Okay, you can see the questions there. Nor Ida has a question. She says that I had lump in my armpit, I think around 12 years ago. I go to hospital for checkup. They said the lump is like an accessory, not breast cancer. Don't know how a lump is an accessory, but she's done mammogram. Now she's 30 years old and the lump is still there. I think same size and condition. Do I need to do checkup again on it? Very good question.
Okay. I have to examine to tell you the proper story. Okay, but from what I understand, high chance your lump is actually not cancerous now. Okay. Okay. There is always a chance for any normal lump. Okay, like fibroadenoma or even some metaplasia cell or anything. Okay, if you keep it long enough in your breast, it can turn into cancer. There's always about 1% chance. So we want to detect that early. So go for your regular screening. You still have to continue with your screening and all. You're already 30 years old. Okay, if you don't have any high risk features, okay, probably you can just wait a little bit, do it at probably 2 years once or so. But once you hit 40 years old, as your age increases, okay, you need to go for your regular mammogram and all.
Okay, got it. So basically go for regular screening. Ariane has a question. She treated for lymphoma cancer. What to watch out for sign of remission? Okay, doc. Good question.
Okay, lymphoma is a blood tumor, so I don't treat lymphoma, so I won't be the best person to answer. Okay, but any cancer, like even lymphoma, leukemia, or solid tumors, or anything also. Okay, once you do any treatment, subsequently say if you're already like cured or you're already like already under remission and all already, right? One sign which always cancer tends to come back is always you'll have loss of appetite and loss of weight. Okay, those are one of the earliest signs that the cancer is activating back again. And then whatever symptoms you have before you had cancer, it tends to reoccur again. So it depends where the cancer go. If it goes to the lungs, some people might have cough, might have blood in the sputum and all. If it goes to your liver, you can have pain in your abdomen, you can have yellowish eyes, your urine might change color. If it goes to the bone, you have some bone pain. So depending where the cancer has gone, that's when you have the symptoms at that particular area. But one of the earliest signs is always you can see you feel very tired, less of appetite, less of loss of weight and all.
Okay, got it. Okay, let me get to the next question. Okay, Tan Q Shing, has question. Hi, doc. At what age a woman should go for breast health screening, breast USG mammogram? I am a mother of one, delivered 2 months ago. Should I go for either breast USG or mammogram?
Okay, generally screening is always by mammogram. Once you hit 40 years old, go for your mammogram. Of course, when you go and do a mammogram, you'll see a doctor there, so they will examine you also. So if you have a very like glandular breast and all, sometimes you need to do ultrasound instead. So this one the doctor will explain to you. It depends on your breast size and all also. But definitely once you hit 40 years old, if you don't have any high risk features, go for your mammogram.
Okay, got it. Do you recommend earlier before 40, just in case?
Only if you have high risk features, if you have family members who have a history of breast cancer, ovarian cancer, then you can go for an early mammogram.
Okay, got it. Chan Lee Hong has a question. Hi, doc. Some say constipation increases the risk of having colon cancer. What are your thoughts on this?
I can only say it's not scientifically proven.
Okay, got it.
Having, I mean, one of the symptoms of having colorectal cancer is having alternate bowel habits like constipation, diarrhea. Okay, those are one of the clinical signs of having colon cancer. Okay, but chronic constipation, I've never read any risk factor of actually having colorectal cancer, scientifically wise lah.
Okay, so Kushing has another question. Still need to perform BSE every month?
Yes, that it's not like a very, how would I say, it's not like a very accurate thing, but there's no harm if you do it by yourself. Even like my patients, once they have breast cancer, I give them treatment, they settle everything, read they're in remission and all. They just do their scan 1 year once. But there's no harm you check your own breast every month once or every 3 months once just to see whether there's anything detecting there or not. If you have a good biology, probably the tumor will take years to grow. But if you have a bad biology, sometimes within 6 months it can grow back again also. Okay, but it
Okay,
is
got it.
not, you cannot use that as a sole screening tool. That is just for yourself. But screening tool, you still need to go for your mammogram.
Okay, got it. Espian's question is, may I know how breast cysts develop and is there any treatment for breast cysts?
Okay, breast cyst is something like an ovarian cyst. It has some relationship with your not menopause, not cyst, with your period. Okay, so some people do get some cysts like when your period comes and your period stops. Okay, a breast cyst practically there's nothing much you can do about it. It's just there. Some people, as you grow old, you can have cysts all over your body also. So breast, you can actually have one of those also. And breast cyst normally, if it's not growing, not causing any symptoms, you don't need to do anything. Unless it's like growing and all, then probably you need to remove it.
Okay, got it. Okay, I hope that was clear. We have another question from Ara Deva Haran. So, hello, doctor. Is it some cancer patient has been diagnosed why is it some cancer patient been diagnosed very late? Some don't experience any symptoms. Any advice on this? What are the cancer tests that we can do? And what is the right age to start doing those tests? Thank you.
Okay, don't remove the question because there's a few questions there. Okay, so why diagnose late? Like I said, it's always individual perception. They have some symptoms, they don't want to do anything, they want to wait for it. But I wouldn't lie, there are some cancers, okay, like stomach cancers, pancreas cancers. Those are very aggressive cancer. Even with nowadays, with all our technologies, right, there's not much. I mean, there are some increase in survival, okay, but these are the cancers which normally, whenever you have symptoms, it is already detected too late. Okay, you cannot detect stomach cancer and pancreas cancer in stage 1, stage 2. You can, but it's very, very rare. Most of the time, it's incidental. Okay, sometimes some cancers, depends where it grows. So if you're talking like lung cancer, you have a very big lung, 20 centimeters, and you just have like probably 1-2 centimeter size of tumor and all, you're not going to have any symptoms because the tumor is so small, it's not compressing any organs. Compared to like pancreas cancer, okay, when it grows, it starts compressing some organs, like colon cancer, you have bowel obstruction, something which is compressing on some things, then only people will have symptoms. So if you have a tumor in a very big location where there's nothing to compress, you won't have any symptoms also. Okay, so cancer tests is always screening. If you're talking scientific wise, screening is the best one. I know a lot of people go and do tumor markers. Tumor markers is taking your blood and then you send to the lab to see whether there's any cancer cells in your body or not. That is not very accurate. It's only 15% positive. Okay, 85% is always negative. You can have a stage 4 cancer and your tumor markers can be normal also. Okay, but tumor marker normally we use as an oncologist as a guide for our treatment. Okay, but you cannot use that as a screening tool. If you're talking for a female, okay, once you hit 40 years old, you need to do your mammogram, you do your pap smear, your PEPAL sampling. If you're talking about men, once you hit 50 years old, you go and do your PSA, your tumor markers. Okay, for men, PSA can be used, and also see the urologist or any doctor for a prostate examination. And then if you're talking about lung cancer, there's low dose CT scan if you're a heavy smoker or you have previous history of smoking. And then colon cancer, once you hit 50 years old, every 10 years once, you can go for a scope, either an upper scope or a lower scope to see for stomach cancers also, and also colorectal cancer. So screening tool is developed to detect cancer early. Okay. Tumor markers is not a screening tool. Tumor markers is just a rough guideline only.
Okay, got it. It's a rough guideline. Okay. All right. So a lot of questions. Keep them coming so that we can answer them. But now let's go into the quiz. All right. It is quiz time, as mentioned earlier. In the show, there are exclusive notebook and pens up for grabs. All right. But what do you need to do in order to win? First, you got to be sure to share this video out at least 3 times. And remember to set the post to public so that everybody can see it. And next, you got to answer the 3 questions that we're going to be showing on the screen in a single comment, and you're on your way to win the prizes. So let me repeat that. First, share this video out 3 times. Remember to set the post to public so everyone can see. Secondly, answer the 3 questions that we're going to show on the screen in a single comment, and we will select the first 3 winners based on speed, the correct answers, and shared posts. So are you guys ready? Let me know in the comment. Okay, and just to let you know, no matter how many times you give me the answers, we're still going to pick the top 3. Okay, so once is enough. Okay, so are you ready? Let me know. Okay, so let's start immediately. First question is, breast cancer was the most reported cancer among females between 2012 to 2016 in Malaysia. Is it true or false? Breast cancer was the most reported cancer among females between 2012 to 2016 in Malaysia. True or false? Okay, Malaysia lags behind developed countries when it comes to breast cancer care. True or false? Malaysia lags behind developed countries when it comes to breast cancer care. True or false? And the last question is, radiotherapy over the last few decades have evolved by minimizing the number of normal tissues being unnecessarily radiated. England also going. Radiotherapy over the last few decades have evolved by minimizing the number of normal tissues being unnecessarily radiated. So remember, put your answers in a single comment, and we're going to select the first 3 winners based on speed, the correct answers, and shared posts. Okay, while waiting for the team to select the winners, let's go back into some Q&A because I just found some really interesting questions. So Chan Lee Hong has another question. Hi doc, under what circumstance that one is advised to go for hook wire biopsy instead of FNEC? Okay, this is very deep. I don't even understand the question. Could you shed some light, doc?
Okay, then again, this is actually a question for a surgeon, actually, not me. Normally, when they come to me, I already have a report. So I don't know whether they went for a FNAC or a hook wire biopsy or anything.
What is a hook wire biopsy? I'm like,
okay. Yes. What I understand, and correct, I might be wrong, okay, but what I see is FNAC is a simple procedure where you actually put in a needle through your breast to the tumor. Now, the tumor need to be of a certain size. If it's big in size, then you can do an FNAC. But if you find a tumor which is very small in size, sometimes the needle, when you poke also, you cannot get because the needle is bigger than the tumor. Okay, so what they do is they will still poke a needle inside. They will put a wire. Okay, they put a wire. That wire is actually a marker. Okay, just put a marker at the breast tissue, and then subsequently they'll remove the needle, and then you go for a surgery. You go for a surgery which is called white local, where you actually do under some image guided, find where is it, and then you remove that whole tissue and you send it to the lab. And when they go to the lab, they need to be able to find that wire. So if you find the wire, okay, we know that we have already removed the tumor there. If you don't find the wire, that means the wire is still inside the breast tissue. Because sometimes the tumor is too small and your breast is so big, even when the surgeon open also, you cannot find the wire.
Right.
So that's why you need a marker for us to identify where the tumor is. And then when the pathologist read it, the wire has to be inside there. So these are for small tumors, if I'm correct.
Okay, got it. Okay, so I hope that answers your question. Yeah, kind of thing. Okay, I think we're going to go into 2 more questions. So Ariane is saying diagnose endometrial cancer stage 2. Yeah, after total abdominal hysterectomy surgery to treat this cancer. Is chemotherapy the only option? Doc, would you say?
Okay. Stage 3 endometrial cancer, if it depends on the cell type again. If you have endometrioid, which is the most common one, okay, the treatment generally for endometrial cancer is always radiation. Okay, not chemo alone. You definitely need to go for radiation even after surgery. Okay, chemotherapy is used as an add-on if you have high risk features like the higher grade, higher stage, a lot of lymph nodes involvement. Then you add on chemo, but chemo is not the only option. You need to go together with radiotherapy.
So that means
And
you
then
need
there's
to
something called brachytherapy also.
who therapy? Sorry, the last one.
Brachytherapy. So radiotherapy can be divided into two. One is external beam, where you do it externally. You lie down the conventional radiation 5 minutes a day, and you probably do it for 5.5 weeks for endometrial cancer. Okay, and then because you need to give a certain dose to the tumor. Okay, but that dose you cannot give through external beam because then your bowels all might get radiated a lot. So then you do something called brachytherapy where we do an internal radiation. So you put a probe inside your vagina, which leads to the endometrial area. No surgery, nothing, just a probe, something like a pen size, very small. Okay, and then they'll deliver radiation internally. So those are
Right.
brachytherapy.
Okay, got it. So it's together with cancer,
Yeah,
or it's okay, got it.
together with
Okay,
the radiation.
together with radiation. Okay, got it. So Irene, I hope that answers question. I have a question, doc. You before that, Andrea J is saying, great topic. Thanks to the doctor for great sharing explanation, increasing knowledge. Well done, doc. Also, I want to say thank you because Cecilia and somebody else actually gave us stars. Yay, that means our content is good. Well done, doc. We got paid in a way with little stars. Okay, and my next question, doc, you actually have a night clinic, is it? Could you share with us what that is?
So our night clinic, I mean, at Columbia Asia Bukit Rimau, we do have night clinics also for some patients who actually can't come during the daytime. Okay, because I do understand cancer patients are generally those elderly patients, so they have kids who are working and all. And there's a lot of problem actually which I see in my cancer patients where the treatment is being neglected and all because those kids are actually working, so they can't bring their parents to the hospital frequently, so they end up having a lot of toxicities and all at home until very late stage where they really cannot tahan, then really they come to the emergency department also. So we always have night clinics to cater for these kinds of patients where really some patients working time they really have to go to work because they're the sole breadwinner or something. So you can actually just come to the night clinic. It's on every Wednesday and Thursday, 5 to 8 p.m.
And this is where you are at
Yeah.
Wednesday and Thursday night clinic. Okay, awesome. So what happens at the night clinic? Is it the consultation part, or it's where they actually get their treatment?
Okay, the night clinic, unfortunately, is mainly just a consultation part. Okay, where you see me, we can discuss about your treatment options and all, what need to be done and all. If you just need something simple like oral treatment, okay, like those oral targeted therapy, oral hormonal therapy, okay, anything which doesn't require any daycare or admission or surgery or anything, you can do it as night clinic. But if you need chemotherapy, then you need to come during office hours because you need a whole
Because
dedicated team to administer chemotherapy and radiation therapy. Well, just a
got it.
clinic, oral treatment is fine.
Yeah. Night clinic, I think, is amazing because a lot of us are very busy, so that really helps a lot. So I think that's good enough. Yeah. Okay. Now let's take a look at the winners because we already have our winners. Can we have a look at the quiz questions again? Let's take a look at the right answers before I announce the winners. So breast cancer was the most reported cancer among females between 2012 and 2016 in Malaysia. The answer is Doc. What's the answer for
True.
number one?
I
Okay.
was nodding my head for every time you ask a question.
So he was giving the answers. I hope you guys got it, right?
Yeah,
Okay, Malaysia lags behind developed countries when it comes to breast cancer care. True or false?
true.
True as well. So radiotherapy over the last few decades have evolved by minimizing the number of normal tissues being unnecessarily radiated. And the answer is true because Doc was nodding and giving away the answers. Okay, got it. Okay, so now let's announce the winners. Let me see who they are. Okay, and the winners are C stars. Congratulations, Ara Deva Haran, Nor Ida. Wow, these two are the people who ask questions. So well done. So I guess moral of the story is if you ask questions, you might just win the quiz. So congratulations to all our winners. We're going to be contacting you after this within a day to get your details. So be sure to check your Facebook Messenger. If you don't, I'll get the prize. Okay, just kidding. Right. Thank you so much, Doc, for today. I've definitely learned a lot. What did you guys learn in today's episode? What was the biggest learning for me, Doc? It was definitely that the clinical trials, right? You said which I think is amazing, and also your case study, fourth stage cancer, and she didn't even do any chemo, and you can really increase the life expectancy. And of course, number one, if you come in earlier with early detection, you can basically basically just get away with a lot of things, I think. So thank you so much. I learned so much today. I hope you got a lot of values from today. Unfortunately, that's all the time we have. So we hope you learned a thing or two. And if you know someone who's really gonna appreciate today's tips, info, and insights from today's show, please share this video out. Tag them, because you never know who it's going to make a difference to, and you might just save a life. All right, so give us a like and lots of love while you're at it. Thank you so much. Till then, take care of yourself and each other. We're going to see you in the next episode. Bye. Thank you, Doc.
Bye bye. Thank you.